My name's Damian McGuinness. I'm the Chief People Officer at King's College Hospitals. I think this is week 5 for me, so bear that in mind as I'm presenting. It's great to be here, and I'm really excited to be at King's. I'm really excited to work with King's Health Partners. From a HR perspective, I think there's a lot we can do in this space, so this has been a great day, and thank you for the invitation. You've got a wonderful guest panel, so if I go down as far right, you've got Ali Bangash, Dr. Juliana Onwumere, I hope I'm pronouncing that correctly, apologies if not, Dr. Rebecca Oakey and Dr. Sarah Crabtree.
That's mine, right. There's no L in there.
Oh, sorry, I beg your pardon. Okay, so firstly, we all know an academic component to clinical roles enhance staff satisfaction, recruitment and retention, and committed to supporting healthcare professionals for our future by fostering positive training environments and research-driven cultures. The King's Health Partners strategy sets out our ambition to strengthen the existing and future healthcare workforce through outstanding education and training opportunities, including King Health Partners Centre for Translational Medicine Fellowships, the King's Health Partners Learning Hub, educational events led by clinical academic groups, King's Clinical Academic Training Office, and the King's Health Partners Digital Health Academy. We will take an evidence-based and personalised approach to training and personal development, and we will track careers, identify gaps, and support people to achieve fulfilling, flexible areas that reflect the evolving needs of healthcare. So thank you for that. I'm going to be very brief in my intro, as you can see, because the guests are wonderful, and you want to hear from them, and we want some good time for Q&A. So I'm going to start with Dr. Ali Bangash, please.
Hello, everyone. Good afternoon. My name is Ali. When I was first asked to present here, I thought I would be presenting to 20 folks on Teams with cameras turned off. So talk about imposter syndrome. But an absolute honor to be here. I am an aspiring psychiatrist trainee. My background is in biochemistry, cellular and molecular biology. Before clinical training, I used to play with proteins, molecules, and genes. And today I'll be talking to you about the Clinical Academic Training Office, CATO, at King's. CATO's mission is to train future leaders in academic clinical sciences. And that includes the entire gamut of medics, nurses, midwives, allied mental health professionals. And the way CATO does this is by building capacities. And some of the programs, specific programs, tailored specific programs that CATO runs are as follows. There are NIHR-funded internships in partnership with ACON and GSTT. These are 10-month fellowships with 4-week research projects. There's this Insight program, 30 funded master's programs. There's a new program called CTN, Center for Translational Medicine, that funds both pre-doctoral and postdoctoral fellowships. And then there's the King's PhD mental health program with 25 funded PhDs over 5 years. And lastly, there's the IAT program, which I am a part of. That stands for Integrated Academic Training. It's an NIHR-funded program. Now, NIHR started this IAT program in the mid-2000s, and the idea was to train medical and dental graduates into research training. And the two main programs that NIHR IAT funds are ACFs, Academic Clinical Fellows, and the clinical lectures. ACFs are primarily pre-doctoral at the IMT core medical training stage, whereas CLs are primarily postdoctoral at the specialty registrar training stage. Over the last 20 years, King's has trained over just under 300 ACFs and over 100 CLs, and more than 80% of the clinical fellows have been active in research, whereas more than 90% of the clinical lecturers have been active in research, garnering over 40 million in research income over the last 20 years. All right, so one of the things that NIHR funds is this annual NIHR conference, and I attended that at Leeds last year. And the two things that I took away from that conference was the fact that NIHR is run by civil servants very efficiently, but they kept harping on the fact that every pound that they invest in clinical research, they get 13 pounds back. And the civil servants emphasized the fact that the first question they ask any potential grant applicant is, so what? What implication does it have on the patient here and now? And as a protein biochemist working with molecules in a test tube and cells in a Petri dish, I mean, that's like 10 years down the line. So that entire conference changed my sort of research trajectory. And now I'm sort of focusing on something called liquid biopsies. So this is already being employed in oncology and fetal medicine, where you sequence cell-free floating DNA and RNA molecules and predict the risk of either oncological tumors or Down syndrome in the case of fetal medicine with the NIPT test. And what I'm hoping to achieve is, we already know that there are these cell-free floating DNA molecules that cross the blood-brain barrier in patients with schizophrenia and first episode psychosis, and whether we can use these RNA and DNA molecules to predict and prognosticate the risk of mental illnesses. I did my PhD at a place called Hopkins, and if you go at the Hopkins campus, you'll see these glass bridges that connect the hospital to the labs. And even at 3 in the morning, you'll see sort of medics going back and forth these glass bridges. For me, the bridge, the one thing that I learned as a non-King's person that I learned about King's was that the campus is sort of vast. And there's an entirely different world at the Denmark Hill campus versus the Guy's and the St. Thomas's campus. And for me, that bridge, that metaphorical bridge was Cato. Because the only opportunity that I had to interact with other fellows in rheumatology, oncology was through Cato. And through that interaction, we are sequencing a very rare syndromic case of schizophrenia that was known to the mental health professionals for over 30 years, but went undiagnosed. And that's in collaboration with rheumatology. I mean, who knew that psychiatry and rheumatology can work together? So a big shout out to James Galloway, who runs this postgraduate program for Cato for the clinical fellows. And that's really the only opportunity for psych trainees to interact with non-psych trainees. And in addition to that, there are these extensive database of research funding that the Cato website has, as well as help with fellowships and other funding applications. All right, lastly, these are some of the contacts for Cato and their website and email addresses. Thank you very much.
Thank you. Thank you, Mike. Thank you, and I'd like to invite Juliana to the stage. Thank you.
Excellent. Brilliant. Welcome, everybody. So I'm Juliana Onwumere. I'm a clinical psychologist and an academic working across King's Health Partners. And Muhammad has gratefully given me a minute more. I'm not going to take it, don't worry. Okay, we know that the importance around inclusivity in research and widening our participation of the many different people and communities in the UK is an issue at heart to many of our funders across the UK. It's also an issue at heart to the HRA, and it's also an issue at heart to the government, to ensure that when we're doing research, it's tapping, it's open to the different people and communities that make up our wonderful society. We also know, however, and perhaps unfortunately, that there is an underrepresentation of people from ethnic minority groups in health research. These people will often be underserved by research. If you are underrepresented, you will be underserved by research. The great research that we do here, the excellence that it produces, both in terms of our intellectual knowledge, our services, and our workforce. But we also know that this happens and does continue to happen in the context of history, where for many groups, behaviours that has often been packaged as research, has led to really poor practices. And in a time when we're less happy or less keen to be with other groups, that has often produced lots of hostility and concern about what research is. But that's really important for us because actually that doesn't exist in a vacuum. That has a direct impact on people's ability and willingness and comfortable to trust in what might be a research offer or research experience. Very much beginning to try and tackle that in terms of capacity, in terms of getting our great minds together across King's Health Partners, has been the Building Race and Equity and Diversity in Research network. So this is a multi-stakeholder network, a cross-sector stakeholder network that's very much been developed to encourage those broader discussions, those sensitive ones, those difficult ones that we often struggle with about race inclusion, about equity in our research as it relates to ethnically minoritized groups. It's about thinking about where they're absent or improving and developing greater policies and procedures and actions that will definitely support greater inclusion and greater equity and greater diversity. It's also about a network that's about very much promoting, not keeping those goods to ourselves, disseminating and sharing good practice. It doesn't always happen on a grand scale, but if we know something that's good in any of our stakeholders, why not share it so people can kind of move with that? It's about trying to maintain a very clear awareness about what's actually happening on a national and an international level when we are thinking about developing greater race equity and diversity in our research. It involves partnering with some of our different stakeholders. I use the South London and Maudsley Trust as an example, where we're able to input in terms of what they do around research and their research offers. But most importantly, it's about working in our communities and addressing those issues around trust and building on that. This is a name check. And I think everyone across King's Health Partners should be incredibly proud to kind of be involved in this. So it's not just our big health providers. It's also those groups that sit behind, that you might not know their names, who have such a significant and strategic role in relation to research and addressing those inequities. It's also, our stakeholders are also our community partners as well. This isn't just our health partners or our educational partners, it's our voluntary and community groups who are involved as well, because if we want to address this, which we are committed to doing, we know that we cannot do this on our own, and that is where the capacity is built. Just as briefly as some examples of our work, we have focused specifically on anti-racism. So one of our partners, the South London and Maudsley Trust, has made a really big role in terms of focusing on how to very much include anti-racism in their research work and their research offer. So we have a specific working group around that. We do some work around identifying what are those barriers. Let's stop talking about it, but what actually are the barriers to inclusivity in our research? If we just think about the comms that we have about our research, you know, when you see in your studies that you must speak perfect English, you must speak fluent English, what does that mean to somebody when they read that? And the clue is that they're reading it. What do we know? I'm sitting here telling you there's an underrepresentation of certain groups in research, but what does that actually mean for your institution? So doing an ethnicity review on your research practice, but also our trust building. So examples of that work, again, this is an example of some work where certainly the South London Maudsley Trust and other colleagues had done a really significant review, 10 years worth of research studies, large portfolio studies, and what they wanted to look at is actually, do they have an underrepresentation? So they wanted to look at the ethnicity and sex breakdown of participants in those studies, compare it to the age, the sex and ethnicity breakdown within the trust, but most importantly, compare it to the sex and ethnicity breakdown in the communities that make up their services. And found actually it was really helpful that there was good alignment. There was good alignment across many of the major ethnicity groups that they looked at, and using that as a model. I'm just highlighting it, but this is a model that people can take and use elsewhere. We've had pilot work focusing on working with our communities, engaging communities and talking about research. Often pretty hard, actually, to hear what people think about research, understanding that there's a lot of myths and lots of misunderstandings, but also a lot of trust issues, and being able to hear that and take that forward. We're really committed to improving our understanding about things. So we have hosted wonderful meetings from the Office of National Statistics, the HRA, from our community colleagues. It's a platform to hear about the really good updates, which often also happen here. These are our colleagues across King's Health Partners as well. And we want to use that data to develop better things. Going forward, as part of some of our strategic plans, we want to move towards just talking about ethnic minorities and being more targeted with the groups that we focus on. Because as you know, ethnic minorities are not one group. The issues that impact someone from South Asia will be very different to the issues that affect someone from a Black ethnic group. We want to make sure we're embedding much more lived experience and focusing on the really underserved groups who come into ethnic minorities, particularly our older adults, people in forensic services, children and younger people. We focus on researcher training and really sharing what we know and focusing on equality impact assessments. That is the direction of travel for Brent. We couldn't do this work without all the people, but I really want to just put a special thanks to Angela, Fiona, Tanya, and all of our BRED stakeholders who make this work incredible and lots of fun. Thank you.
Thank you so much. And could I just remind people just to post some Q&A, please? We're going to have a good bit of time with the panel at the end. And just on that note, just to read out Amy Hall, just a comment that I'm so pleased to hear this topic being discussed by Juliana, and lots of thumbs up from that on the audience. Thank you. Now, Professor Rebecca Oakey, thank you so much.
Thank you. So thank you very much indeed for this opportunity to discuss and show you our fantastic training opportunities. So King's Health Partners Digital Health Hub originated with a bid that Professor Seb Orselin orchestrated and led for bringing some cohesion to some of the training that we have in our really strong areas of digital health. So the idea of the Digital Health Hub was to create an accessible multidisciplinary resource supporting digital health and clinical data sciences around 4 pillars. So the 4 pillars are the training pillar, which infiltrates all of the pillars and beyond. A co-creation pillar, which speaks to our public engagement and patient engagement tools for creating really good, accessible means to engage with everyone and all the stakeholders involved in this complicated digital health area. A translation and an acceleration hub, all of which bring together expertise from across KHP, patient and public representatives, the NHS and social care representatives, and industry partners to support, enable knowledge transfer, and create opportunities for accelerating digital health in the UK. So this is the training pillar team. Learning technologists are really essential to bring really good, animated, easy to digest, self-directed learning into a community of healthcare professionals and beyond. So the focus of this whole idea is to have the ability to convey empowerment through training. And so we generated the Digital Health Academy. It's really based on the things that we felt that were missing from the kinds of accessible training that are needed for people who have too much to do. They're not registered for a degree, they're just trying to get on with their job, but they really need to embed some of this very fast-moving digital training into their work lives. And so we wanted to increase digital clinical engagement in digital health, boost digital literacy in healthcare, and build commercial skills within academic environments. So we wanted to build on success, and we did this by building on a training program we'd already started. And one of the things that's really important is this training is mapped to the training, all of our training is mapped to the NHS AI and Digital Healthcare Technologies Capability Framework, so that it matches what you need and isn't just a random collection of training that you don't know where to start or whether it will be useful for you in the future. So this program was plinth on something called the Innovation Scholars Program. There are lots of self-paced courses that are delivering digital skills, right from very, very basics. Do I need to know any digital skills in my job, or will my job eventually lead to some kind of digital skill acquisition that I need? And it delivers right into the heart of using AI in healthcare analytics, machine learning, programming, and things that perhaps are on the interface between using and leading. And we host these training courses on the KHP LearnWorlds platform, so it's fully integrated with all the other courses that KHP offers. And we do it in partnership with KHP Education, and Dr. Claire Mallinson, who is here today, is the Director of Education and Training for KHP, and we work in harmony to share best practice and also not to generate any duplication. So the impact of our current training around digital skills is incredible. We've got over 9,000 users at the moment, and if you look at the distribution, it's very global. And importantly, when you break down who's using it, we can see we have clinical users, allied health professionals, students, all sorts of different practitioners across health and much beyond. So we are accessing quite a broad range of learners. So we've been able to develop this a lot further using a national network. So we're not only offering now asynchronous self-paced learning, but for those who need to take it a little bit further, we've got some in-person workshops that have been funded by UKRI to just help those who need a little bit of extra one-to-one tutoring. So in 2024, we launched an entrepreneurship course in digital health, and I think this was something that an earlier speaker alluded to with Lucy. Thinking about entrepreneurship is really important if you want to take digital inventions, and we did this in partnership with Julie Devonshire and the Entrepreneurship Institute, and we've got very good uptake of these modules, which helps you to think about how you might want to move forward with an idea that you have, regardless of what role you are in when you're thinking of these ideas. We have a co-design pillar, which is led by Glenn Robert, Louise Rose, and Away Liu, and these are not only courses and resources, but there are methods, libraries, and workshops and in-person group settings where you can learn how to make the best use of your patient and public engagement opportunities. And then we also have a translation and acceleration pillar where we have courses on ethics and information governance for AI. And Cass Gibson has generated some fantastic content that provides an accessible open source course for learning what's important to know if you're going to use AI in health. And we've also got some understanding medical software and regulations and quality in healthcare. Again, another facet if you're going to take your ideas further. One of the fantastic things about KHP is its ability to reach across different entities, and we've been very fortunate in partnering beyond the KHP Digital Health Hub with Pharos AI, which is a federated learning environment to advance cancer breakthroughs. And in this case, we've been working together to seamlessly connect all of this training and push it further into other areas of the partnership and make sure that we are really nailing the kinds of training and learning that people need to make that connection between the trusts, the universities, the industry partners, and making sure there are no gaps in understanding how you get your digital health invention through to where it's needed to meet that patient interface. So with that, there's a QR code to the training page where you can have a look at what we deliver, and I encourage you all to have a little click and see what level you need to enter the training. It's all described in a linear and in a network pattern, so you can work out what you know and what you don't know and where you enter and what you need to do from there on. So thank you very much.
Thank you so much. And finally, but not least, Dr. Sarah Crabtree.
Perfect. So we've heard a lot about public involvement and public engagement today, and I don't really want to provide you with more information, but I'm hoping that I can provide a bit more of a visual, partially thinking that public involvement isn't just about information and knowledge, but also about that cultural change that needs to happen alongside. So as mentioned, I work in patient and public involvement across King's Health Partners Centre for Translational Medicine, and also within our palliative care teams and nursing midwifery and palliative care faculty. One thing I will add to this is that I'm also a HCPC registered music therapist, and it's through my music therapy and research background, which is in music therapy and dementia care, that my inspiration for patient and public involvement really kind of comes to life. So I worked in dementia care homes as a music therapist for several years. And before starting my PhD, I'd asked some of my colleagues in the care homes where I worked, what are some of the challenges that you face? What needs addressing? And they often said that later stages in life are the most difficult. Patients or kind of residents in care homes are unable to talk, unable to move around, and they just don't know how they can keep them engaged in the life of the care home. So starting my PhD with this in mind, I was struck by the number of challenges that I was faced. Ethical approval challenges, the potential for residents to pass away and therefore not collecting good data. And it just left me thinking, what is the point? If I just do research that's easy, who is going to be doing the research that's difficult, that the people, the public, care staff and our patients actually need? So with this in mind, you might be thinking, where is what we do now? So within our KHP strategy, PPIE is often referred to as a golden principle. And for today, I'm going to be talking about it using the analogy of kintsugi, which is a Japanese method of repairing pottery with gold or other valuable materials. So you can see that in the image. And this is based on the philosophy that the history of an object is something to be celebrated, and that the story of the pot makes it more beautiful and desirable. Meaningful PPIE is not just one part of the research or a piece of the pot, and it's definitely not a missing piece, which in the research world might be your gap in knowledge, which your research question can fill. But PPIE is this golden glue, which is interwoven throughout the pot. And similar to this idea that the pot tells a story, the golden glue of PPIE reminds us that the stories of individuals who will one day benefit from our research will be affected. With just the golden glue, there is no pot. And with no clay, the pieces can't stick together. So the collaboration and recognition of the different strengths is where we see the true benefits in our healthcare system. PPIE is crucial not just because it's the right thing to do, but it also makes better science. And it's important that, to research that is also recognized by funders who often make it a requirement in research funding. So where does capacity building fit into this? And in many ways, this is where my role comes in. My role in PPIE is to support researchers to become the potters by being able to logically put together pieces of the pot or pieces of the puzzle in their research, but also to think creatively and imaginatively when gluing and using that golden glue and working with the public. By equipping them with the tools and the skills, they can also become the kind of sculptors of our healthcare system. To provide a couple of examples, at the earliest stage of research, the Center for Translational Medicine offers PPIE pre-grant funding. And this supports researchers to involve PPI members while designing the project and before grant funding is received. We also work closely with other groups across the university, such as the King's Clinical Academic Training Office, Cato, which we heard about earlier. And most recently, at their Cato Symposium, where we organized a first ever PPIE award for clinical academics across KHP to encourage and share case studies of good practice, which again, you can see in our image. I also work quite collaboratively across King's Health Partners, and in a recent survey, staff members recommended a network to be developed to share resources for staff, opportunities for PPIE members, and to raise awareness of various events, but also to provide an opportunity for meeting others who provide support for kind of designing our pottery. I was pleased to launch this network in September, and it's already being used to develop an online training course on the foundations of PPIE. Our next step is to bring community partners into the network to ensure that they are also equal collaborators in our research. Recognizing the different strengths of our staff and local communities is needed, similar to utilizing all of the diverse strengths of the pottery pieces and the glue. Along with several researchers we fund, we were able to join various other groups at the STEM Big Top Tent at the Lambeth Country Show. And as an example, we had families testing their grip strength and for the kids kind of being like the Hulk, which you can see in the left image above. And we also hosted a 3-day Pint of Science event with King's College Hospital Clinical Research Facility and shared research in dermatology, genetics, and AI, along with an evening to celebrate International Clinical Trials Day. The image on the right. At the Center for Translational Medicine, hearing from our communities is a vital part of how we work. For each of our funding review panels, we have 2 public member panelists asking interview questions, feeding into the panel discussions, and scoring our applicants. We've also worked closely with Diversity Resource International, a community interest group that supports ethnically diverse and migrant communities. And through working together, we can reach into our local communities to ensure we include the less heard voices on our interview panels. Unlike research, PPI specifically isn't a space for strict systematic approaches, but a space for adaptability and creativity. But in all artistic processes, technique and logic must work with the flexibility and the imagination to develop something of beauty like the Japanese pots. Similarly, our communities are just as important in designing the pots as our researchers, healthcare staff, and others who support the delivery of healthcare in the UK. In the future, I feel like I can speak on behalf of others when I say this as well, that we would love to see more equal partnership where we support our local communities as much as they support us. Recognizing the cracks in the system is an important part of recognizing our healthcare story and being aware of where attention is needed. So I'm going to leave you with one last thought, that when PPIE is done in a meaningful way, we bring together the pieces of our healthcare professionals, patients, communities, by putting these pieces of the pot back together and binding them with this golden glue that strengthens the pottery, mends the relationships, and in the long run will make our healthcare system stronger than ever. Thank you. I look forward to the discussion.
Thank you so much. I think we're putting up a Slido link, so please do have the questions coming in. As that's happening, I'm going to open up with a generic question for the panel, and please come through, either one of you, which you feel strongest. What's a change you've seen across the health system that was made possible by partnership? Don't leave me hanging.
Oh.
Either of you, yeah, any one of you.
Well, I'm happy to go. I think certainly within the Bread Network, it's actually been incredibly helpful to bring so many different people together and very much dispel the myth that this wasn't an issue that people think about. Actually, lots of people are thinking about it. They are. It's just sometimes a very confusing place or confusing area to kind of be in. So I've found that incredibly helpful.
Thank you. Anyone to build on that?
I will give you an example from my own world, which is when this first came out, it was in the world of mice, which is these antibodies against plaques in the brain that cause Alzheimer's. And over the last 20 years, clinical trials have shown sort of mild to moderate benefit in patients with Alzheimer's. And that sort of partnership between sort of basic science, sort of lab-based work, and this translation into sort of clinical world, is really brilliant.
Thank you. Question for Juliana and Sarah. How can we truly co-design strategies or improvement programs with PPIE rather than treat it as a tick box exercise?
Should I take this one first? So I think in many ways, the important component is also listening. And I think it's when we listen to our partners that we can really have a kind of conversation that addresses kind of the needs of the community partners, the needs of our staff, kind of the researchers, the healthcare professionals. And I think in that kind of strategy building process, it's the listening that needs to come kind of right at the beginning. That it's only when we listen to our partners that we come up with more really interesting and kind of unique ideas as well that kind of both parties would never really have thought of. I mean, there's a lot that we can say on some of these questions, but
I would add to that as well, though I think what's incredibly important, and I do think you don't say yourself so well, but actually lots of people need training on how to do this. It's not a natural thing. We talk about PPIE, some people don't even know what that means. And I think that's what's really fantastic today, because you do have these little gems of resources that are out there and funding to kind of help people to do things differently. It's not a natural thing that everybody knows. This is still relatively quite new.
Maybe if I could just add to that we've looked at the pillar of co-creation, co-design training as a really central part to helping everybody take on board what this means, so that training begins right at the beginning, and then if you need something very sophisticated for your grant, you can look at what you need to build into that, but you can actually start right at the beginning and understand what listening means. And I think that those workshops that we offer are really supposed to be for everyone, not just trainees who say, oh, I didn't know I had to put PPIE into my grant, but all the way through the learning journey, right from the beginning to the end.
Great. And in an extension of that, our most liked question, how can these opportunities get through to frontline staff who are exceptionally busy?
So we have evidence to show our frontline staff who are exceptionally busy are taking our training, because we've looked at who's taking the training. And we do two things. One is we make them CPD accredited so that they can get time to do that. And secondly, they are free and you can do them anytime on your holiday, when you're in the bath, all those places where the only time you have to have is to, even if you explore what they mean, you don't have to pass anything. It's about enlightenment. It's not about homework. And I think that's where we start with all of this training. It's comms and marketing we're struggling with, but we hope KHP will help us a bit more with that, sending it out to those people who are really struck for time.
And in my day job, I was going to pick up the comms part, and you were recognising that is not a challenge. I don't want to put it in that domain, but comms is particularly important. So how would I know about these events if I wasn't here today?
Yes, that's exactly right. Yeah, I think that's very important.
And anyone got any advice that we can take back to our organisations?
I mean, I find it, for us certainly within the BRED stakeholder network, it's really important, and this is for everybody here actually, people are sent information.
It's really hard to digest
Let's just be clear. People are sent information. Instead of hogging it, share it. That's what's really important, because there's lots of stuff out there, and actually brilliant stuff, what we have locally. The issue is it's not all, people just don't get to see it. And it's not because it's been hidden. So when you are on networks, when you are in committees and people do share stuff with you, do send it out.
I think one of the things that we struggle with is also that there's so much out there. People don't know which is the one for them, and they don't know which one's a good one and a bad one, and they don't know how to rate it. So a branding like KHP can lend some kind of credibility to the quality, and then also we are responsible for designating who an average user could be. And I think that's what we've been trying to do. And I don't know whether that's, so obvious when you're looking at all aspects like entrepreneurship, so everybody knows if they want to be one of those or not. But at this level, I think that's really important.
I think I would just add as well that this is where I think the cultural change comes in as well, that if the conversation is already part of the teams that you work with, it's much easier to integrate into your kind of day-to-day work. Yeah. And it doesn't become an extra thing that you have to do, it's just part of your job. So the same way we might think about, let's do a literature review to look at the gaps in the research. Part of that kind of determining the gaps in the research also needs to be how do we reach out to the communities to find out what their perspectives are as well. But if that conversation happens as part of the culture and part of the team, it all just happens as one thing, not okay, now you have to do this extra piece of work. And I think that, that's where I think the cultural change comes into it.
Thank you so much. Ali, I wonder if you mind if I bring you in more of a generic question. Yes. What advice would you give to others who are just starting out their career in health and life sciences?
The one thing that I've learned is that the way science still works is through mentorship. There's this famous book written by somebody who showed that the 70 to 80% of the Nobel Prizes are won by folks whose mentors have won a Nobel Prize. So there's this lineage you can sort of draw. So finding the right mentor is the key. And then just do it, just get involved. You can only test the depth of the water by stepping in it.
Fantastic, thank you. Professor Oakey, a question for you, please. There's clearly some fabulous training in digital skills available across KHP. Mm-hmm. Are there any plans to evaluate this impact on upskilling researchers and health professionals, and how might we do that?
So in terms of the impact, what we're doing, a number of things. One is we look at who completes the course, we look at the numbers of people in different disciplines who complete the courses. So we look at the relevance of our training. And secondly, there's underneath all of this, there's a thing called an accelerator. So one measure is to see how many people bring their idea into this hub and end up with a marketable output. And so there's lots of training that helps you to get into the hub, and then looking at where do people stall along that way? So is it in the ideas? Do we not get the right ideas? Are we not getting the person putting a body into a scanner is getting stuck? That person needs to come up with an idea, bring it to the hub, think about what training they need, push it through with the right PPIE training into some kind of accelerator. So he's getting that idea all the way through to the end. So I could imagine that measuring how many endpoints we have is one way of measuring whether people who came with nothing, in terms of accept the idea, make it at least part of the way through the pipeline to a thing, a Fitbit, a necklace, something that improves health in some way or other.
Fantastic, thank you. Stakeholder, Fred. Sounds like a much needed initiative for health research. Interested whether Juliana has any examples of ways researchers have overcome distrust within the community to build sustained and reciprocal relationships between community and research teams.
I know you shouldn't answer questions by saying that's a great question, but I do think it's a great question. What I will say, though, is it's really important that we just have to start recognising that there isn't one community and there isn't one person to represent the community. When we were doing our pilot work for speaking with communities about research, there was such a range of people, even people that might look the same in terms of their experiences and their histories and their stories. I think what's really important, and we say this in Bread, that the lack of trust, mistrust, no trust, is not the end of the conversation. It must be the start, because our research is linked to our service excellence. It's not an option for us not to be included, but also it's not an option to not engage. So it's an iterative process. You just keep going.
Thank you. And if I was in that position and I came to you as in a mentorship capacity and I said, I'm going into an environment of mistrust, what would be your top tips for me, do you think?
I think it's really important for us to think about what we're trying to do. It's not an answer to everything. What is it that you're trying to do? Who are the voices that are missing from what you're trying to do? And be able, I think, as Sarah said, it's not a small thing, and it's not something that we're taught very well, is being able to listen. Don't just come in with your answers. Can you listen what I've said? That's really important.
Thank you so much. Sarah, can I come to you on a different question? That's okay, please. We've heard how we need a workforce fit for the future. How do we use capacity building in our partnerships to overcome organisational boundaries and deliver truly integrated mind and body care that reflects the future workforce? And the rest of the panel, please feel free to come in. It's a big question.
Yeah, I guess kind of talking more specifically on the PPIE side. I mean, in the work that I do in the kind of partnerships, there are quite a few challenges in working across the different kind of NHS trusts, the university, and I guess this is where the kind of collaborative side comes in, because it's only through those conversations that we can start kind of identifying some of those challenges and really kind of address those challenges head on. I mean, one in particular that I see really frequently is kind of access to community groups and patients. And obviously kind of from the NHS side, there's patient confidentiality, which is kind of very rightly so needs to be there. But then there's a question of, how do we reach out to those members from a kind of university perspective as well and make sure that their voices are also heard. So yeah, I guess not an easy answer. But I have seen that through some of the collaborative conversations that we've been having, that we are starting to address that, and it's bringing in the strengths and the skills from different areas as well, where we can say, okay, these people are experts in maybe kind of the expenses side, and they can share information about how the kind of behind the scenes processes works for expenses, and then maybe thinking about how public members might maybe want to be reimbursed, and it's bringing in those skills from very different areas. So collaboration, I guess, in summary.
I also think, just in terms of just following on from what you're saying, Sarah, I think the collaborations between organisations is so much easier in many ways. Even today, you can network, and I can take your number and email, and that's lovely. But in terms of for our community organisations, which is really much, much harder, but it's harder for the right reasons, because our communities do say that it's really difficult for people just to helicopter in, because I want to find out more about this. Even though our intentions might be good, the timing just generally doesn't fit so well. And then we run into the issues around the money. But there's different ways that we can be in reciprocal relationships. We have a lot of knowledge, we have lots of skills, lots of other things that we can share. And I think it's more trying to understand the language of the different groups that we're working with.
Absolutely. There was a great example, if I can add a little bit. I was at a Southwark Council event at one point, and they were saying, one of the community leaders in the event was saying that their community is sustained by grant funding. And they were saying that within their team, they don't really have anyone with the expertise and the skills to be able to kind of successfully write those grant funding applications. And I just sat there thinking, we're a university, we have hundreds of people who can do this well. Surely this is a way we can work together. And even if we start thinking about kind of PPIE events where the first hour is talking to them about grant funding tips and that kind of mentorship from our end as well, and the second hour being kind of their feedback into our research, kind of why is that not something we've done? That seems like a really easy, straightforward thing. But often it is a simple solution. It's talking to the right people and hearing the right things.
Thanks so much. Ali, I wonder if I could ask you to lead, and I think others will naturally come in. So the question here is, how do you share your learnings from your work with the wider system? And there are any barriers to sharing the learning on digital, EDI, PPIE, and academic careers?
So the most obvious route is through publication. I think that's there's a transformative change happening in that world. I don't know if people have heard of bioarchiving, which is the idea that before actually sending a publication out for formal publication, you can put out a preprint. And that's something that's just happened in the last 15, 20 years, to the point that preprints are now also indexed in Medline. And so it's really and that really has opened up the avenue to sort of disseminate your work. The second change that has happened in the last 10, 15 years, or maybe 20 years, is open-ended journals, which basically does not require a monetary subscription to sort of access journals. So there is a drive to sort of be more open-ended and more proactive in disseminating work. There's a saying in my world that everyone, before Twitter went nuts, every academic needs to be on X to sort of propagate your publication. But I think now LinkedIn has taken over that role. So you got to be on these social platforms one way or the other, even if one is a bit autistic.
But I think extending that, which I think what you said is really helpful in terms of, we know that even with the funders, they want to know, even if it doesn't interest you, but they want to know the different ways that you demonstrate your impact. Because what you were saying earlier about that £1, and they look about the £13, and we know that, for publications are wonderful, and they're brilliant, and whatever those metrics are. But I think what you see across King's Health Partners and different groups is just actually what's the target end audience want? And so we know there's different things. So we've had things such as doing podcasts and doing talks, doing magazines. It's just really thinking about what is the best way of communicating what you want to the groups. But I really will add, though, actually, for many groups, and particularly the underserved groups, but this is across the board, one of the biggest issues that we can change just overnight is making sure that when we are doing research, we are sharing that with people that we have worked with, because that's one of the biggest gripes. We're all around when we want to get the money or the glory, but not sharing it with the people that have helped to do that.
Fabulous. The last question in 2 minutes. Sarah, Rebecca, could either of you answer, how do you find the space for acknowledging and addressing the role of intersectionality in determining access to participation in research? And if that is an unfair question for you, I'll ask others to help.
A long question.
I mean, I would probably start by kind of echoing what Juliana had said as well, that, there isn't just one community. And I think for me, it's recognizing that every single individual has their own story. We kind of often say, we've got our PPIE group, and that's what informs our entire project. But that's kind of 6 people, or however many that might be. And they're 6 individuals who kind of, even as a group, might have their own perspectives and their own opinions. But I guess thinking, how do we reach further? How do we kind of recognize the individuality of every single person as well? Because everyone is just different.
Yes, so
that's where I'd start. But
yeah, so I've worked with national patient entities, groups like Amend and so on, where you have people come because they want to, and there's no limit to who can come. If you're on a particular in a particular ology, this Amend group will embrace you, and you come in, and there are researchers and clinicians all working together to have a day of questions and really sort of accessible presentations. And it's quite challenging, because you feel like you're not reaching everybody, because everyone's there for a different reason and has a different quality of experience. So I think it's very challenging.
But I also think it's really good in terms of looking at, you know, who's using your services, who's accessing training. But I think for us, which, again, I'm not just banging on about it because we are in King's Health Partners. If you look in King's Health Partners, there are some really good pieces of work that people are trying to do and have done, and really thinking about who the missing voices are, being open to feedback, knowing that, you know, for BRED, for us, it's not just about, you know, being a participant, thinking about the different ways that people can influence research questions, the research process, or being in advisory roles, and most importantly, just thinking about what those barriers are and trying to change them.
Fantastic. Slightly overrun by 20 seconds, but can I give you a round of applause to the panel, please?